Now you must understand that glenohumeral joint, acromioclavicular joint, sternoclavicular joint, and scapulothoracic articulation. This forms the shoulder girdle. All movements are interrelated. The humerus has a very minimal osseous support, the shallow glenoid fossa in the shoulder as compared to the deep acetabular socket. So all the dynamic stabilizers, they are of very much importance. They are the muscle, ligament, capsule, and all other soft tissue structures which helps in the shoulder stability as the humerus is hanging from the shoulder joint from the glenoid. The common attitudes are Erb's palsy, the clavicle almost subcutaneous clearly visible from the observation inspection. We can judge dislocation of shoulder, the scapula spangle deformity, which we can see. Also, winging of the scapula can. On the inspection, posterior aspect, lateral curvature of spine, and excessively kyphotic thoracic spine, the Schurman's disease or juvenile kyphosis. From the inspection, you can judge about the sternoclavicular joint, clavicle, grossly about the contour and muscle mass of the shoulder, the axillary fold. Lateral aspect, you can also judge about the acromioclavicular joint, and on the posterior aspect, you can have judgment about the spine, the scapula, the spine of scapula, the counter of the trapezius muscle, the gross muscular variations which are on the posterior aspect. Now the bony palpation, it starts from manubrium sterni, then the sternoclavicular joint, the clavicle, the most curved lateral concave portion of the clavicle, then coracoid process. Again, we can judge about the acromion, the acromioclavicular joint which is lying here. The greater on the anterior aspect, you can have lesser tuberosity, the bicipital groove, the greater tuberosity, the lateral border of the acromion. On the posterior aspect, posterior border of the acromion, the spine of scapula, the flattened triangular area, the from there the superior portion of the scapula, the vertebral border, the lateral border, and the inferior angle of the scapula. These are the structures or the bony palpatory structures. Rapidly see palpation of the acromioclavicular articulation, easier when patient rotates. This is the way you palpate the coracoid process, the way of palpating acromioclavicular articulation. Palpate the anterior aspect of acromion, palpate the bony dorsum of acromion and the lateral aspect. Palpate the greater tuberosity of the humerus, the bicipital groove and the lesser tuberosity by externally rotating the arm. You are always sitting or standing behind. Rotate the shoulder joint with the help of flex elbow and using the arm, and you can palpate the lesser tuberosity, the bicipital groove with biceps tendon and the greater tuberosity. These are the structures which you are palpating on the posterior aspect. Here, it is very simple that scapula is located between 2 to 7th rib, and the medial part of the medial triangle of the scapula is at 3rd rib, 3rd vertebral process. The distance between the spine of the spinous process of the vertebra and the thoracic vertebral distance is around 2 to 3 centimeter of the medial angle of the scapula. For the soft tissue palpation, first is the seat muscles, supraspinatus, infraspinatus, and teres minor muscles that are part of the rotator cuff in first portion. The subscapularis is difficult to palpate, which is lying on the anterior aspect. The second zone will be the subacromial subdeltoid bursa, third zone will be the axilla, and fourth will be the prominent muscles of the shoulder girdle. The method of palpation of rotator cuff, which lies underneath the acromion, passive extension of the shoulder moves the rotator cuff into the palpable position. Now for subacromial and the subdeltoid, the portion of subacromial subdeltoid bursa are palpable when they extend out from the under of acromial edge. Here we extend it out. We also rotate the arm for palpation of subdeltoid bursa. Third important zone 3 for soft tissue palpation is the axilla. Now axilla is a pyramidal in shape. This is the method of palpation of the medial wall of the axilla. Now probe for the lymph node arrangement, probe for the serratus anterior and medial part of the rib, palpation of the brachial artery that is on lateral aspect along with the bicipital tendon and coracobrachialis muscle. You can also palpate the latissimus dorsi, the posterior wall of the axilla with this method. You can palpate the anterior wall of the axilla and pectoralis muscle by this method. Now, zone 4 is the prominent muscles of the shoulder girdle. The method of palpating the sternocleidomastoid, that is the first number of the muscle, it starts from its base, the two heads are there, and again it going about, both are palpable simultaneously. The neck is rotated on one side to make the opposite side of the muscle stronger. The sternocleidomastoid should be palpated simultaneously. Next, you have to palpate the pectoralis major muscles. It starts from the costochondral junctions. You can palpate from at the clavicular head. You can palpate the lateral portion where it inserts and it forms the anterior border of the axilla. Costochondral junction, costochondritis, we can judge. The palpation of the biceps. Palpation of the biceps starts with the palpation from its insertion, go above, palpate the bunch, palpate the long head of the biceps and bicipital tuberosity. Elbow is fist, and we are making the biceps muscle prominent, that helps us in easy palpation. Here we are palpating the entire deltoid muscle, the anterior portion, the middle deltoid and the posterior deltoid. The spine of the scapula, it is palpable and it is difficult to separate it. The spine of the scapula, below is the deltoid and above is the trapezius throughout. The method of palpating the lower angle of the trapezius muscle. This is the upper part of the trapezius muscle and this is the insertion. The palpation of the rhomboidus major and minor as a unit, and again the medial angle, medial small triangle at the end of the spinous process, and up to the inferior angle we can palpate the rhomboidus. Now, method of active range of motion, the Appley's scratch test, the external rotation and adduction, that is the first position, the second position for internal rotation and adduction, and the third position for internal rotation and adduction. This is the method of palpating the shoulder abduction. The arm is supinated, arm is touching above, the hands are touching above the hand. The elbow is extended. The test for abduction motion occurs at glenohumeral joint and the scapulothoracic joint. 2-1 for first 20 degrees. The scapula is fixed, only glenohumeral pure motion is there. Check that movement occurs at the glenohumeral joint or only the scapulothoracic articulation, the movement is there. Shoulder abduction can continue up to 120 degree, where 90 degree is at the glenohumeral, 30 degree at the scapulothoracic region. After the greater tuberosity touches the acromion, external rotate and the further movement is done so that major articular surface covers the comes in contact with the glenoid. Maximum abduction is possible, and here the articulating surface of humeral head turns the surgical neck away from the tip of the acromion. Muscle testing in form of the group flexion, extension, internal rotation, external rotation, and abduction and adduction. Neurological examination is done. Manual muscle testing is done from 0 to 5 degree. First is extension, that is primary extensor, and the secondary extensors. This is the shoulder test for the shoulder flexion, test for the shoulder extension. Now for abduction and adduction, these are the tests for shoulder abduction, test for shoulder adduction. Similarly, we have to palpate about the external rotation and the internal rotation. So the group of the muscles, the primary and the secondary, can be palpated simultaneously. Other three MMTs are movements are the shoulder elevation. This is the method of shoulder elevation. This is the method to palpate the shoulder retraction or position of the attention, and this is the method for shoulder protraction. Again, the winging of the scapula, you can push against the wall also or do the push-up. Reflex which are tested, they are the biceps and the triceps. The dermatomes, the regimental that is C5 because of the axillary nerve. Again C5, the T1 lies here, T2 lies here, and this is T3, T4 and T5. The special test that we will deal in a separate session.